Assalamu alaikum, everyone. This is Dr. Zahra. I'm going to be your panelist today, along with Dr. Khulud. We have 3 lectures today, starting with conduit choice in infective endocarditis by Dr. Firas Fatani, followed by surgical treatment for aortic valve endocarditis by Dr. Rami Al-Ghamdi, and finally, journal club about the ART trial by Dr. Sireen Murshid. So, Dr. Firas, if you're ready, you can share your presentation, and we'll start at 1:05. All right, Dr. Firas, you can go ahead and start.
Okay. Assalamu alaikum. So I'm Firas Fatani, R3 cardiac surgery resident from King Abdulaziz University Hospital. My topic will be a conduit choice in infective endocarditis, a journal club. So the outline of the presentation, I will appraise an article about conduit choice, and then I leave the floor for discussion. So this topic was discussed in the previous year for conduit choice of infective endocarditis by Dr. Muhammad, and the conclusion was that we needed, there was no specific valve type that can be implemented valve choice, since the recommendation did not show that, and the studies presented. And since last year, I was looking for an article on that type. There was no randomized clinical trial. The newest article was mechanical versus biological valve prosthesis for left-sided infective endocarditis. So this is a single center conducted in single center study conducted in Austria. So to analyze this topic, what is the question asked in this article? So they said the aim of this retrospective study was to analyze outcomes after mechanical versus biological valve replacement during surgery for left-sided infective endocarditis at the Department of Cardiac Surgery, Medical University of Vienna. Their hypothesis was that implementation of mechanical valve prosthesis in the setting of left-sided infective endocarditis would be associated with higher risk of re-endocarditis and consequently higher all-cause mortality during follow-up. So the population, the peak of the study, their population was patient who underwent left-sided infective endocarditis surgery at the Department of Cardiac Surgery, Medical University of Vienna. Their intervention was bioprosthetic valve replacement. The comparator was mechanical valve replacement. The main outcome was all-cause mortality and the incidence of re-endocarditis. So the significance of the study, as you all know, those patients who have infective endocarditis are predisposed to higher risk of recurrence and poorer prognosis in case of prosthetic valve endocarditis. And that also recent guideline involving this matter did not provide specific recommendations for the superiority of a specific valve type in this setting in patients who have infective endocarditis. So, conflict of interest. Three authors reported conflict of interest with receiving institutional research funding from companies associated with and providing valves for cardiac surgery. Ethical considerations. The Institutional Review Board of Medical University of Vienna approved the study and individual patient consent was waived. So the inclusion criteria for the study was patients who were aged 18 years at the time of surgery, 18 and more years at the time of surgery, patient receiving mitral or aortic valve replacement for infective endocarditis, and either mechanical or biological prosthesis. Exclusion were patients who underwent repair, cryopreserved homograft, or purely right-sided infective endocarditis. Follow-up, the primary endpoint was all-cause mortality. The median follow-up period was 4.3 years. 77 patients or 35% deceased during the follow-up period. The secondary endpoints were occurrence of combined event during follow-up. The combined event was defined as death, stroke, intracerebral bleeding, or reoperation, and risk of re-endocarditis. So they measured continuous variable as mean, and they described it as mean and standard deviation, or as median and interquartile range. Categorical variables were described with absolute frequencies and percentages. Baseline characteristic, clinical and echocardiographic findings, operative characteristics were comparatively analyzed using students' t-test, chi-square test, or Fisher's exact test. Kaplan-Meier survival curves visualized all-cause mortality. Two-sided p-value less than 0.05 were defined as statistically significant. All statistical analysis were performed using STATA 16.1 software. So baseline characteristics. So mechanical valve was patient were 40. The mechanical valve patient were receiving mechanical valve were 76, 34.5. Biological valve was 144, 65%, 65.5% of patients. Mean age was 46.1 plus or minus 13 for mechanical, and 63.3 plus or minus 13 for bioprosthetic valve, with statistical difference of p-value less than 0.01 with more receiving by prosthetic valve. Euroscore was lower in mechanical valvular group with statistical difference of p-value 0.002. NIHA class major criteria there was no statistical difference. In minor criteria, fever was more in patients with mechanical valve, the statistical difference of 0.025. Prosthetic valve endocarditis was more in patients with biological valve with the statistical difference of 0.012. Other variable like cardiogenic shock, CPR, lactate level, LV function, preoperative antibiotic and atrial fibrillation were not statistically significant. Majority of all patients who had cancer received biological valve with majority of patients who had stroke in their previous 48 hour received biological valve. So blood culture, majority of patients had staph and strep. 50% of the patients. Enterococcus fecalis was 16%. Negative blood culture was present in 25.9% of patients. So the study period was divided into 2 eras between 2009 and 2013, and between 2014 and 2018. And you can see that there is increase in the use of biological valve over time. Full stenotomy was in patients, 92 patients who received mechanical valve and 97 patients who received biological valve. Re-stenotomy or redo surgery was not statistically significant. Most common used prosthesis in the mechanical group was Abbott Masters, and the most used in AVR patients was Abbott Master, and in the biological group was Edward Magna Ease, 34% of patients, and Medtronic Mosaic as 32% in patients who had AVR with biological. In mitral valve replacement, mechanical group received CryoLife Onyx, 95%, and Medtronic Mosaic mitral valve was in 85% of patients receiving biological valve. The majority of patients who had concomitant coronary artery bypass grafting surgery were in the biological group. So data analysis in patients who were less than 55 years of age, there was statistical significance of better all-cause mortality in patients who received mechanical valve. And this was demonstrated by multivariable Cox proportional hazard regression analysis. In patients who were more than 55 years of age, implantation of mechanical valve prosthesis was not associated with the risk of all-cause mortality. And here is a Kaplan-Meier demonstrating the patient who received patient population of less than 55 years of age who received mechanical valve and bioprosthetic valve, and you can see that all-cause mortality is better in the group receiving mechanical valve, demonstrated in the red. So this is the table of Cox regression for survival analysis. And you can see in age group less than 55 years of age, the variables of mechanical valve prosthesis, lower Euroscore, lower lactate had a p-value of significance for better survival. No statistical difference for such variable in patients who are 55 years of age or more. So secondary outcome, 110 patients, 50% experienced a combined event as defined previously as death, stroke, intracranial bleeding, or valve-related reoperation. And individual analysis of combined event component demonstrated that patients who were less than 55 years of age who received mechanical valve were associated with lower risk of combined event. Implantation of mechanical valve prosthesis was associated with significantly lower risk of death, intracranial bleeding, and valve-related reoperation. Reendocarditis occurred in 26 patients. A trend of decreased risk of reendocarditis was observed in recipients of mechanical valve prosthesis, but there was no statistical difference. P-value was 0.093. Annular abscess was associated with increased risk of reendocarditis. And you can see here in this graph, the combined event related to in patients who received mechanical or bioprosthetic valve with age less than 55 or more than 55 years of age. So the main study findings are as follows. In the population of less than 55 years of age, mechanical valve was associated with a superior outcome in regards to all-cause mortality, intracranial bleeding, and valve-related reoperation in the primary and secondary endpoints. In the age group of more than 55 years old, no association of all-cause mortality or combined event were observed. So the potential confounding factor that I noticed was the small sample size of the study, 220 patients, and this will not be will not be sufficient to have a power and recommendation for this matter. This is a single center and it will not represent the general population. The short follow-up period of 4.3 years. They had a cutoff age of 55 years old. As we know in the guidelines, the cutoff point is higher in the bioprosthetic valve. And that may cause some confounding. So the correlation between previous research and practices, and does this add any new in this topic? So there are three previous researches that I discussed. This aortic valve replacement for active infective endocarditis, 5-year survival comparison of bioprosthesis, homograft, and mechanical prosthesis in 2010, and it involved 167 patients receiving prosthetic valve 18%, homograph 16%, mechanical valve 65%, and they had similar result in that lower mortality in patient receiving mechanical valve, but their cutoff was 65 years age. And they also did not have statistical difference in the older age group. Their older age group was 65 years old. The second article was outcome of surgery for infective endocarditis, a single center experience of 801 patients in 2018. It was also a single center. The mean age was 60, and it did not show statistical significant in all-cause mortality between valves. But it showed that there was no statistical difference. In the third study, bioprosthetic versus mechanical mitral valve replacement for infective endocarditis in patients aged 50 to 69 years, and it was published in 2020. It looked into mechanical valve prosthesis in Hubei province in China. They had a high population of 8,000, but they received mechanical valve for different reason, and they used propensity score matching, and they had a population size of 500 after propensity score matching. They did not have statistical difference in the all-cause mortality, but there was increased risk of stroke in patients with receiving mechanical valve, and major bleeding in case of mechanical valve also. The reoperation was more in the bioprosthetic valve, and bioprosthetic valve had more prosthetic valve endocarditis. So as you can see, there is a correlation between some kind of correlation between previous studies, but they did not, even this study did not show, did not provide good evidence for recommendation of specific valve type in patients who have infective endocarditis. So I'll leave now the floor for discussion. Thank you.
Thank you, Dr. Firas, for the nice presentation. Anyone has any comment or things they'd like to add? Feel free to go. Okay, then. Seems that we can stop now, go for a break, 5 minutes, and we'll be back by 1:30 or 1:31 with the next lecture. Okay, Dr. Rami, go ahead and start.
Okay, good afternoon, everyone. Today, inshallah, I will speak about surgical treatment for aortic valve. This. So we will go through introduction, timing, and indication of surgery, preoperative consideration, surgical management, and complication. So infective endocarditis is the most severe and potentially devastating complication of the heart valve disease. The aortic valve is the most common valve affected by infective endocarditis. More than half of all patients have been operated during active phase of the disease. Early diagnosis is extremely important to avoid its complication, including heart failure, cerebral embolism, and death. Among patients with aortic valve infective endocarditis, congenital bicuspid aortic valve is the most common predisposing lesion. Other lesions, including degenerative calcific aortic stenosis, rheumatic valve disease, or aortic regurgitation due to any cause. Prevention of endocarditis is important in all patients with valve disease, both before and after valve replacement or intervention. So microbiology of aortic valve infective endocarditis depend on whether the valve is native or prosthetic, and whether the infection is hospital or community acquired. Staph aureus and Streptococcus viridum are the most common organisms responsible for aortic valve endocarditis. And we can see in the picture how the endocarditis affecting the cusp. Fungal infective endocarditis is rare but extremely serious and very difficult to eradicate and cure, usually associated with large vegetation, as it's seen in picture A, while in picture B after removal of the vegetation. So prosthetic aortic valve infective endocarditis classified as early if it occurs within the first year, or late when it occurs after 1 year from the surgery. Early prosthetic valve endocarditis commonly caused by staph epidermis, Staphylococcus aureus, and Enterococcus faecalis. And usually the source of this infection preoperative bacteremia or contamination of operative field during implantation. Late prosthetic valve endocarditis mostly caused by staphylococci and streptococci. Usually the source here is difficult and to determine, but related to an invasive procedure such as dialysis or dental procedure. So what is the indication of surgery? The first indication is the heart failure. In case of aortic or mitral infective endocarditis or prosthetic valve endocarditis with severe acute regurgitation or valve obstruction of fistula causing refractory pulmonary edema or cardiogenic shock, this patient will take in as emergency basis. It's a class 1 level B. And the second, aortic or mitral infective endocarditis with severe acute regurgitation or valve obstruction and persisting heart failure, or echocardiographic sign of poor hemodynamic tolerance, early mitral closure, or pulmonary hypertension. It will be taken as urgent basis, class 1, level B. Aortic or mitral infective endocarditis, or severe prosthetic dehiscence with severe regurgitation and no heart failure. This patient can be taken as elective. It's a class 2A. Second indication is prevention of embolism. Aortic or mitral infective endocarditis or prosthetic valve with large vegetation more than 10 millimeter following one or more embolic episode despite appropriate antibiotic therapy, or large vegetation with more than 10 millimeter and other predicted complicated course such as heart failure, persistent infection and abscess, or very large vegetation more than 15 millimeter, taken as urgent basis. It's a class 1. The third indication is the uncontrolled infection. In case of locally uncontrolled infection, abscess or false aneurysm, fistula, or enlarging vegetation, urgent basis is class 1. Persistent fever and positive blood culture more than 7 to 10 days, not related to an extracardiac cause. This patient taken as urgent, it's a class 1. Infection caused by fungi or multi-resistant organism can be taken as urgent or elective. It's class 1. Prosthetic valve endocarditis caused by staphylococci or gram-negative bacteria. Most cases of early prosthetic valve endocarditis, this can be taken as urgent or elective. It's a class 2A. So the preoperative consideration, coronary angiography is recommended in patient age 40 or older, especially in this if the patient had at least 2 cardiovascular risk factor or had previous revascularization. In case of large vegetation, CT coronary can be performed to avoid dislodgement of vegetation particle. Preoperative CT chest have to be done when re-sternotomy is required. All patients scheduled for surgery should have neurological evaluation by CT or MRI. Delay the valve surgery is usually advised in patients with more serious neurological complication. So neurological complication, the embolic events are associated with the increased morbidity and mortality in infective endocarditis and occur in 20 to 40% of patients with the infective endocarditis. The risk of embolism is highest during the first days after the initiation of antibiotic treatment and usually decreases after 2 weeks. Early surgery is associated with the reduction in the rate of embolic complication in patients who present with the left-sided infective endocarditis, severe valvular heart disease, and large vegetation more than 10 millimeters. Patients with ischemic stroke should delay their surgery 1 to 2 weeks, while those with hemorrhagic stroke by 3 to 4 weeks. So what is the recommendation in case of neurological complication present? If cerebral mycotic aneurysm has been diagnosed, treatment and follow-up of patient should be in close collaboration with neurologic and neurosurgery expertise. It's a class 1. In patients with recent intracranial hemorrhage, a delay of operation for 3 or more weeks is reasonable. It's a class 2A. Earlier surgery is reasonable for patients with non-hemorrhagic stroke and strong cardiac indication for urgent surgery. It's a class 2A. Patient with large vegetation, patient with large and multiple stroke and severe neurological symptoms should be carefully evaluated by a neurologist before being offered surgery. It's a class 1. For patients with infective endocarditis and neurological symptom and significant intracranial hemorrhage, angiography should be considered to rule out mycotic aneurysm. It's class 2A. So treatment. Antibiotic therapy should be started soon after obtaining at least 2 blood cultures. Timing is important because destruction is progressive and disintegrated cusps do not heal or regenerate. The patient should carefully monitor for signs of congestive heart failure, coronary or systemic embolization. Surgery should be immediately considered if there is an evidence in echocardiogram of enlarging vegetation or increasing aortic regurgitation, paravalvular abscess, or poor response of clinical symptom to antibiotic. It's ideally to operate on patient before they develop complication, such as acute heart failure or cardiogenic or septic shock, heart block, or stroke. Surgical management. The standard approach through median sternotomy. Intraoperative TE is mandatory. Myocardial protection via antegrade and retrograde blood cardioplasia with repeating of retrograde cardioplasia every 15 to 20 minutes. We need to avoid unnecessary cardiac manipulation before arresting the heart. Aortic valve usually exposed through transfer aortotomy about 1 centimeter above the RCA origin. Minimizing the residual contamination by discarded instrument and gloves used to debride the contaminated area before reconstruction is begun. So the recommendation regarding choice and reconstruction and valve replacement, this is general consideration. For patients with the native valve endocarditis and infection limited to the valve cusp or leaflet, Repair is performed whenever is possible. It's a class 1. When simple valve replacement is required, choice of valve, mechanical or tissue prosthesis should be based on normal criteria, age, life expectancy, comorbidity, and expected compliance with anticoagulation. It's a class 1. It's reasonable to avoid use of mechanical prosthesis in patients with any intracranial bleeding or those who have suffered a major stroke. It's a class 2A. For patients with invasive disease and destruction, reconstruction depends on the involved valve, severity of destruction, and the available option of cardiac reconstruction. It's a class 1. So in case of non-invasive infective endocarditis, for limited localized infection and preserved control of the cusp, an attempt can be made to repair and preserve the valve. If repair is failed and the infection is limited to the aortic valve cusp, removal of the cusp and replacement of valve is required. The choice is based on usual criteria, as mentioned earlier. In case of prosthetic valve infective endocarditis, if annulus and root preserved after radical debridement, it's reasonable to implant a new prosthetic valve. Second scenario, in case of invasive infective endocarditis, if the infection is invasive beyond the valve cusp, affecting the aortic root, radical resection of all infected tissue and foreign material, prosthesis, bridged, and sutures is necessary. Adequate debridement is followed by reconstruction. LVOT is almost always preserved to allow direct anastomosis to allograft. The intervalvular fibrosum is the landmark. It's corresponding to the base of the anterior mitral leaflet and 2 trigon on either side. And it's guide and help the guiding to reconstruction and indicate the level of proximal suture line. LVOT is sized with the Heger dilator, allograft with an internal diameter 2 to 3 millimeter less than the annulus diameter is chosen. The coronary button should be well mobilized and re-implanted to allograft in anatomic position. So here, this is an example of a patient present with sepsis and heart block. In any case of infective endocarditis with the heart block, we should open and inspect the right atrium. In picture A, we can see the prosthetic valve infective endocarditis. The arrow is indicating the vegetation on the sewing ring. While in picture B, after they open the right atrium, same patient with perforation is visible in the right atrium. Picture C, we can see the after debridement, destruction in AV node location is seen. It's the same in picture D. After complete debridement of all infected tissue, RA reconstructed. We can see the arrow indicated. RA is reconstructed with the autologous pericardium. In picture A, the aortic allograft is sutured to the LVOT. And then picture F, the allograft is tied down and well seated, allowing the debrided infected area to communicate and drain to the pericardium. Complication. So postoperative complications are common after surgery for active infective endocarditis. Sepsis is common in this patient, present with vasoplegia and hypotension, coagulopathy and excessive bleeding due to prolonged cardiopulmonary bypass and extensive debridement. Surgical bleeder and adequate hemostasis should be achieved before administered protamine. Heart block can be caused due to radical debridement of invasive disease with periaortic cellulitis and abscess, for which permanent pacemaker sometimes will be needed. Neurological deterioration may occur in patients with pre-existing cerebral emboli or as a new event, multi-system organ failure. The clinical results show the prognosis of aortic valve infective endocarditis depend mainly on when and in what stage the disease is diagnosed. the offending microorganism, and how promptly is treated. Surgical results depend on many variables, including patient characteristic, timing of surgery, violence of organism, whether the affected valve, native or prosthetic, or infection has extended into and beyond the valve annulus. Patient with the prosthetic valve infective endocarditis had worse prognosis than with the native valve endocarditis. The result of surgery for infective have improved significantly over the time, but still in hospital mortality remain high. Thank you.
Thank you, Dr. Rami, for the very informative lecture. If anyone has any questions or comments, please go ahead. All right, this brings us to the end of this session. For the next session, Dr. Khulud will take over. Thank you.
Okay, we will resume our third lecture at 2 p.m. Okay, Dr. Serene, can you kindly prepare your slides?
Okay, shall I start?
Yeah, sure, go ahead.
Okay, Assalamu alaikum wa rahmatullah. This is Sireen Murshid from Al Medina Cardiac Center. Today, inshallah, we're going to present in Journal Club the ART trial, which is the comparison between bilateral and single internal thoracic artery grafts at 10 years. It's a randomized trial that compared the bilateral with the single ITA grafting for CABG at 10 years. The primary outcomes was death from any cause, and secondary outcome, death from any cause, myocardial infarction or stroke. It's a multi-center study done in 28 hospitals in 7 countries and published in 2019. The benefit of using lift ITA has been well established to their superior and long-term patency in comparison to saphenous vein grafting in many studies. Many studies have shown lower long-term mortality when using both right and left ITA in grafting. In addition, they found excellent long-term angiographic patency of right to be similar to the left ITA. So they came with the hypothesis that routine use of right ITA in addition to the left one would provide better clinical outcomes. The inclusion criteria were patients with multivessels disease whom scheduled for CABG, including urgent CABG, with exclusion of patients whom planned for only single graft surgery or concomitant valve surgery, or if they have a history of CABG or evolving myocardial infarction. All patients randomized into 1-to-1 ratio for 2 groups, bilateral or single internal thoracic artery grafting, surgery to be performed within 6 weeks of randomization in order to minimize any event between randomization and surgery. Here we can see the total number of enrolled patients in the trial, which is 3,102 patients divided into 2 groups, the bilateral group, which were 1,548 patients, and the single group, 1,554 patients. Patients who actually received the bilateral graft were 1,294 patients, and the patients who actually received the single graft were 1,494 patients. And there they have exclusion in each group. Patient in bilateral group, number of 215 patients received a single graft, and 38 patients in a single group graft group received bilateral grafts. After 10 years of follow-up, they have a 314 died patient from the bilateral graft group, and 328 patients died in the single graft group. After 10 years, they have 1,198 survival in the bilateral group and 1,189 patients in the single graft group. Bilateral group a bilateral graft group, both right ITA and left ITA were anastomosed to the most important coronaries in the left system, and could be used as composites graft to each other, plus supplemental vein or radial arteries to other coronaries based on clinically indication. Anastomosis to the RCA was not permitted because of concern about inferior long-term patency. And about the other group, which is single graft group, single internal thoracic artery to the LAD, plus supplemental vein or radial to other coronaries. Surgeon could be participate in the trial only if their experience included 50 or more operations using both right and left internal thoracic artery grafts. Standard methods for anesthesia and myocardial protection were used according to local practice. And participating center encouraged to provide evidence-based preventive medical treatment for all patients underwent CABG. About the outcomes, the primary outcome was death from any cause at 10 years of follow-up. And secondary outcome were the composite of death from any cause, myocardial infarction or stroke, rate of repeat revascularization, and safety outcomes, including bleeding and sternal wound complications. Statistical analysis they used in this trial, sensitivity analysis with adjustment for age younger than 70 years old versus older than 70, sex ejection fraction less than 50 or more than 50%, and diabetes if the patient have it or not. Time to event analysis of survival was performed with the use of long-run methods and Cox proportional hazards regression to estimate hazard ratio and confidence interval. Competing risks analysis was used in the analysis of myocardial infarction, stroke, and cause-specific mortality. Pre-specific subgroup analyses were performed on the basis of baseline diagnosis of diabetes, age, and type of surgery if it was performed on pump or versus off pump, radial artery grafts, number of grafts, and ejection fraction less than 50 or more than 50. Pre-specified exploratory analysis for the primary outcome, including per protocol analysis, which is only patients who actually received their randomly assigned treatment, and as treated analysis, the treatment that they received regardless the treatment that they were assigned to. This analysis is important. You should pay attention for it. They compared, it will make a difference in the result later on. They compared patients who received at least 2 arterial grafts, left internal thoracic artery plus right ITA or radial or both of it, with those who received a single arterial graft. which use of lift ITA with multivariables adjustment for imbalance in baseline characteristics in both groups. The results, the groups were well matched with respect to age, sex, race, body mass index, systolic and diastolic blood pressure, smoking status, and coexisting condition. Uh, 83.6% of patients in bilateral graft groups received bilateral internal thoracic artery grafts, and 14% received only a single internal thoracic artery, and 96% of the patient in single graft received single internal thoracic artery. This crossover was observed that it's generally lower among surgeons who performed more than 50 cases. So somehow it's depend on the surgeon's experience. Approximately 40% of the patients underwent CABG, off-pump CABG in both groups, and mean number of vessels grafted was 3 grafts. It's around 50%. And there were 19.4% in the bilateral grafts group received radial artery grafts, and 21.8% from the single graft group received radial artery graft. Here we can see the medication at 10 years of follow-up. We can see it's well balanced between the two groups. Aspirin used an average of 81% in both groups, and beta blocker in 71 in both groups. Statin in 90% of both groups, and ACE and ARBs in average of 72% in both groups. The primary outcome of this trial, a total of 644 patients, which represent 20.8% of overall trial population, had died by 10 years. 315, which 20% in the bilateral group, and 21% in the single graft group, with a hazard ratio of 0.96 and confidence interval 0.8 to 1.1, with a p-value of 0.6. And here, as we can see in this figure, it's almost the same. Both lines are going up together. It's almost adherence to each other. So there is no difference between the two groups we have. And approximately half of the patients or half of the deaths were classified as being non-vascular, non-cardiovascular cause mortality, around 10% in each group. And going back to the secondary outcomes, which represent 25% from the bilateral group and 27.3% in the single group. And also, as you can see, it's not statistically significant between the two groups. There was no significant between group difference in the rate of repeat revascularization, 10% of each group. and also the same as the major bleeding, around 3% in each group. And about the sternal wound complication, we have 3.5% from the bilateral group and 1.9%, which represent 2% from the single graft group, with a hazard ratio of 1.8 and confident interval 1.1 to 2.8. So we can see here some sort of statistical significant external wound complication between the two groups. This showed the secondary outcome in both groups. As we said, there is no statistical significance between two groups. Okay, intention to treat analysis. It defined as all participate who are randomized are included in this statistical analysis and analyzed according to the group they were originally assigned to, regardless what the treatment they have. So in this, we can see there is did not show any evidence of significant interaction between the two groups. In the per protocol analysis, including only patients who underwent surgery according to their randomized assignment, the result regarding the primary outcome were similar to those in the intention to treat analysis. As you can see, it was 20% in both group in intention to treat analysis, and it becomes almost 20% in the per protocol analysis. So there was no difference between two analysis groups. As treated analysis, as we said, it's compared between patients who received multiple arterial grafts with those who received a single arterial graft, regardless of randomized assigned to. We can see that 315 deaths among patients in the bilateral, on the multiple arterial grafts, which represent 18.6%, and 307 which represent 23% in the single arterial graft group, with confident interval between 0.6 to 0.9. And in secondary outcome, we can see 23.6% in the multiple arterial graft group and 29% in the single arterial graft group, with statistical significant confident interval. Here we can see there is a difference between the two lines or the two groups, here with the primary outcome and here with the secondary outcome. We can appreciate the difference between the two groups. In intention to treat analysis, there were no significant between group difference in primary or secondary outcome, and this result not consist with the previous studies, which suggest potential benefit in mortality reduction in the use of second internal thoracic artery for grafting. There are several possible reasons. Incomplete incomplete revascularization, evidence showed that complete revascularization, even with the vein graft, it's improve survival and give the patient more benefit than incomplete revascularization. The second cause of this conclusion that 14% of the patient in bilateral graft group received only single internal thoracic artery, and 22% of those in single graft group also received a second arterial grafts in form of radial artery. And there was a mini trial has shown that the use of radial artery graft was associated with superior angiographic patency and better clinical outcomes. So the use of radial gives benefit for those in the single graft group. And as we saw in the result of as treated analysis, that difference in mortality in favor of multiple arterial graft group was clear. These questions of comparison between the single and multiple arterial grafts, you can take a look for it in a Roma trial. And the third reason for the result of this trial was crossover rate. 14% of patients who had assigned to a single received single in bilateral graft group, and which may have influenced the relative effectiveness of bilateral internal thoracic artery grafting. In addition, intraoperative conversion to the other procedure also result in higher rate of adverse clinical events. And the fourth reason they give its medical therapy. Adherence to guideline-directed medical therapy in patient undergoing CABG is increasingly recognized as a major determinant of clinical outcome, including survival. So this may have served to narrow the difference between the two groups. Another explanation of the lack of superiority of bilateral ITA grafting in the ART trial was the age. Improved bilateral intrathoracic artery grafting was seen only after 10 years. And also in the New York State database, they showed that the survival advantage of multiple arterial graft was seen after 7 years. So therefore, CABG patient undergoing bilateral ITA should have a life expectancy of at least 7 to 10 years to have the benefit of the bilateral ITA grafting. Comorbidities, patient with comorbidities that result in life expectancy, limit life expectancy, are also unlikely to benefit from the grafting of bilateral thoracic artery. Sternal issues, as we saw, there is a significant difference between the two groups in sternal complications. So patient at risk for sternal complications such as obesity, diabetes, insulin use, frail patient with osteoporosis, or patient with chest deformity, or patient using steroid, they are not advised for bilateral ITA grafting. And distal target vessel stenosis, the degree of distal target vessel stenosis is also an important factor in determining the suitability for bilateral ITA and multi-arterial grafting. ITA grafts have decreased patency in vessels with less than 70% stenosis, while the radial grafting is best of patient with at least 80% stenosis or more. Limitation of this study, it's unblinded trial, and there was no follow-up angiogram or studies of myocardial viability, which limits the consideration of graft patency and pattern of ischemia. This was my presentation. If anyone has any question, any comment.
Hello, Dr. Rasselin. So what I understand that you are saying in general that we don't use the, or they recommend that we don't do the total arterial revascularization for high-risk patients, and then we can use that in young patients, for example.
Yes, exactly. This is the conclusion of this study, was that patient, if the patient is a high risk or old or elderly patient, it's not, there's no benefit of using bilateral artery or multiple arterial grafting in this patient. There's no any superiority for them. But in young patients, they have some superiority of bilateral or multiple arterial grafting.
Yes.
Dr. Serene, thank you so much for the presentation. I have a question actually from your side. Would you offer your patient bilateral or total arterial grafting, or you would use single artery like Lima-1280? The others are vein. And what is in your institution, or what you have seen?
As reviewing this article, if my patient is young and they don't have the risk factors for chest infection and has a good long-term survival, expectant life survival, so I would prefer for him the bilateral or multiple arterial grafts. But if the patient is already elder patient and or a comorbid patient, which I'm not expecting that long survival, I wouldn't give him the risk of infection, of chest infection, or even the graft patency failure in nothing, yani. So if the patient it's mine, I would do as risk benefits comparison between the procedure I will do. But in my center, I didn't see that much bilateral grafting, bilateral ITA use. And even the radial, we didn't use it that much. But if the patient is young enough and it's doesn't have a diabetes, we think about the bilateral ITA grafting.
I see. You know, I'm asking because what we are doing, we're doing in our center as Lima-1280, and again, if I look to the chart here and this study, I find that there is inferiority and there is no difference between two of them. But from my side, if it is no difference, why I would harvest 2 arteries from the patient and I expose the patient for a wound infection. Would you agree with me, or you have another idea?
Actually, this study has a limitation because they didn't compare between a radial or arterial, and venous. But of course, we have superiority of arterial grafting than venous graft. So I think I can take the risk, or I will accept the risk of taking arterial grafts in patients more than venous.
Mohammed, what
But
about
you-
the pedicled and skeletonized?
I mean, even if we skeletonize and have bilateral internal thoracic arteries, there is still more chance of having infection compared to single use, especially in diabetic patient. And most of our patients are diabetics. I'm not sure. For now,
Yeah.
it's only
This
10 years.
is the
There
one
is
of conclusion, actually, which is if the patient has a risk factor for infection, it's not, don't use the bilateral ITA for them. And this is what we do actually in our center. If the patient have a diabetes, we will not consider aslan a bilateral ITA harvesting for them.
I see. Anyone else have a comment or who wants to share what they are doing in their centers? Okay, Dr. Serene, thank you so much.
Thank you.
Okay, we finished the third lecture, and I think that's it for today. Thank you, everyone.